Addressing the needs of unique patient populations is our episode topic. My guest is Lauren Bruwer, clinical nurse specialist at the Cleveland Clinic's Digestive Disease Institute Center for Human Nutrition. We'll discuss how her CNS role is vital to creating a patient-specific service line to deliver clinical expertise to unique patient populations, while also promoting evidence-based practice and driving nursing practice to addressing gaps in the healthcare system. So let's get started.
Welcome to the BRG Nurse Executive Podcast. BRG is a global consulting firm that helps organizations in disputes and investigations, corporate finance, and performance improvement and advisory. BRG's healthcare performance improvement practice offers multidisciplinary services to healthcare organizations. We focus on implementation with innovative, independent, and data-driven solutions. In the BRG Nurse Executive Podcast, we discuss improving patient care by advancing nursing leadership. For more information about BRG, please visit thinkbrg.com. Now here's your host, Nick Chmielewski.
Lauren, thank you so much for joining us today.
You're welcome. It's nice to be here.
Before we get into our episode topic today, can you share a little bit about yourself with our listeners?
Sure, absolutely. So I was actually born and raised in the city of Durban, east coast of South Africa. And nursing is the only career that I ever considered. I started nursing school at the age of 17, and I graduated from St. Augustine's College of Nursing in Durban, South Africa, as a registered nurse and a registered midwife in 1995. I additionally hold a diploma in behavioral health nursing and community health nursing from St. Augustine's College of Nursing, and worked as a registered nurse in South Africa for 8 years prior to coming to the United States to work. And so in 2003, my husband and I moved to the USA to take advantage of a travel nursing opportunity at the Cleveland Clinic. We arrived on May 29th with just 2 bags of luggage and $5,000 and started life all over again. But here we are, 21 years later, proud citizens of the United States. The journey's been challenging. The hardest part has been being away from our families who all still live back in South Africa. But the opportunities that we have had to build our careers and build our lives here are unmatched, and especially the opportunities that we can now afford our 16-year-old son makes all the personal sacrifice worthwhile. Having worked in both a third world and a first world country, I believe those work experiences have really given me the opportunity to become to develop a very well-rounded perspective of healthcare and nursing. I've had to work on both ends of the spectrum, where I've used newspaper to make diapers for adult patients because we didn't have enough supplies. And then on the other end of the spectrum, I've worked in areas where medical supplies are in abundance. So I really do have a very well-rounded perspective on what it's like to work in healthcare. But one thing that is very universal around the world is that the clinical acumen and scholarly application of nursing care really does drive patient outcomes around the world. And so I think the role of the nurse is absolutely pivotal in healthcare. I pushed forward with my nursing education and I obtained my advanced practice degree and clinical nurse specialist certification from the Kent State University. And I've never looked back. I absolutely love what I do. And I've been in nursing for many years and absolutely I love the opportunity to interact with the patients and to drive patient outcomes, and specifically love the opportunity to take care of patients with unique needs.
A lot of our nurse executives right now are considering, or they actually are in the process of utilizing an international nursing program. And so you essentially went through something similar to that a little over 20 years ago.
Mm-hmm.
What was it like to come into the United States and get a nursing license, albeit 20 years ago? So this may be a little bit dated in terms of what an international nurse's experience is today.
Yeah, so I can only speak to my experience, but it was a pretty rigorous process 20 years ago. To get a license to work in the United States, I needed to pass the NCLEX exam because your license doesn't just transfer from one country to another. Certainly didn't just transfer from South Africa to the United States. And so I actually went through a pretty rigorous process of testing out and studying for the NCLEX board exam for almost a year prior to coming to the United States to actually do my board exam. And so that was all just preparation. I would have to do a test every week and fax it over to the United States to be graded. And a lot of that is because there is financial assistance that is offered to come over and take your board exams. And so they want to be sure that you're going to be a successful candidate. Plus, just bridging some of those gaps in the differences. I worked with a different unit of measurement for measuring blood sugar and kilograms versus pounds and stuff like that. And Fahrenheit versus Celsius was even different. And so just learning all of those intricacies, although I'd already been a registered nurse for 8 years, I had to learn some things differently. Nursing care is pretty universal around the world, but there are some nuances that we had to tweak out. So it was really nice to have the opportunity to prepare well in advance. I then came I'd never left the shores of South Africa, but I flew into New York City by myself. And then from there on to Jacksonville Beach, Florida, where I went through an NCLEX review course, again, just in helping in preparation for the actual exam. And then I actually did my board exams in Jacksonville Beach, Florida, but through an affiliation with the University of New York, and was successful with my board exam, which then allowed me to go through the license application process for obtaining a license to come and actually work in the United States. But given the timing, I actually flew out of New York City just 10 days before the Twin Towers came down. And that was just devastating because at that point, obviously just the most tragic thing that can ever happen, I feel like, in history almost. But also then there was a hold was put on any foreign nationals trying to come into the country. And so it took 2 years to actually process my paperwork, my license, my green card, everything to be able to come and actually work. But I'd made the commitment, I'd passed the board exam. And so we just sat it out and we waited until everything was processed. And once I received my license and my green card, we made the trip over. And here we are.
So that entire board exam process happened before 9/11, and then there was a
Yep.
2-year delay, and then
And
after
then there was
9/11.
a 2-year delay. Yeah. So ideally, I think at that time, the process should have taken about 6 months, but the delay was a consequence of 9/11. And so for us, it looked a little different. But I tell you, I never lost hope that entire time. The folks in the United States kept such great contacts. They kept us up to date with everything that was going on. And they were still very determined to have me come over and work here as a nurse. And I'm really glad that we persevered with that opportunity because it's been life-changing for us.
The folks that you're referring to, are these folks at the Cleveland Clinic, or you also mentioned a university in New York that helped you with the NCLEX prep? Who was responsible for what? It sounds like there was a good academic practice partnership going on there.
Yeah, absolutely. So it's actually, there are international recruitment companies. And at the time, it was an international recruitment company that was working to do all the licensing and the legalities of getting your license, your green card, all the legal stuff that allows you to work in the United States. So that was an international recruitment company, but they partnered with the Cleveland Clinic. So the Cleveland Clinic partnered with them, and then they worked together with a recruitment company in South Africa. So it's like 3 people, almost 3 different teams working together to make it happen. That's how it worked out for me at the time.
Thank you so much for sharing that. I know it wasn't our episode topic, but definitely information value added for our listeners. Last year in season 2, episode 20, Mitzi Saunders discussed the role of the clinical nurse specialist and the various strategies that a nurse executive can employ to leverage clinical nurse specialists in their organization. In this episode, we're going to provide an example of just that. I understand you worked on a team that created a service line at the Cleveland Clinic for patients with enteral access devices. Can you tell me a little bit more about that?
There are a lot of very unique patient populations that have unique needs. And sometimes there's a struggle in getting the unique needs taken care of because oftentimes patients, and specifically my patient population, and that's patients that are dependent on a feeding tube or enteral feeding. The feeding tube is as a consequence of another underlying disease process. And so it might not be that you have something wrong with your gastric anatomy that you need a feeding tube, but maybe you've had a significant stroke and you're no longer able to swallow. And during that acute phase while you're in the hospital with having the stroke care taken care of, you required a feeding tube. And so a feeding tube was placed. And then you transition out of the hospital and the stroke care continues, and there's extensive rehabilitation to get mobility back and speech to work on speech. And oftentimes what I noticed was that these patients, when they had a problem with their feeding tube, it was a real struggle for them to find somebody to manage the feeding tube. It is not always a clear-cut line as to when the feeding tube was placed, who placed the feeding tube. Like I said, if you're here for another underlying pathology and the main focus of your care is a stroke, but you do need a feeding tube because you've lost the ability to swallow, you may go to a procedural area during your hospital stay, and whoever's working in the procedural area that day is the person who's placing the feeding tube. Doesn't necessarily mean that you will have an opportunity to follow up with that provider afterwards, or you may not even know who that provider was because at that point you were still very acutely ill. And when things become complicated or there's questions about the feeding tube, patients really struggled to find access to care. And so that really piqued my interest. I saw that there was this gap for this patient population. And so I had a very strong interest in enteral nutrition. I developed my interest actually while I was working as a clinical nurse specialist with the neuro patient population, purely because they are such high consumers of enteral nutrition. And that's where I really started to notice the gap. So when the opportunity for me came to work within the Digestive Disease Institute, and specifically with the patient population who are dependent on feeding tubes for their source of nutrition, I jumped at it with both hands. But I also knew there was a lot of work to be done in that area. And clinical nurse specialists have such a significant impact on patient outcomes, nursing practice, and system and organization sort of initiatives. We drive the quality metrics, we improve healthcare outcomes, we promote clinical inquiry, we ask those probing questions. Why isn't there a service line for this patient population? They have such unique needs and they struggle. So why don't we have this? Asking those probing questions and then looking at the literature, generating research, even these are all things that clinical nurse specialists do. And then taking that into the hospital setting and looking and seeing what do the nurses in the hospital setting feel about taking care of patients with feeding tubes? What is their comfort level? What is their competency level? And is there an opportunity for me as a clinical nurse specialist to elevate nursing practice related to this patient population? Additionally, as a clinical nurse specialist, I can provide direct patient care. And so I can diagnose, I can treat, I can prescribe. And so I feel like the role is just so well suited to starting a service line for this unique specialized patient population. It's really like a one-stop shop to be a clinical leader, a clinical expert, a clinical visionary, and a real asset to any organization that's looking to serve a very unique and specialized patient population. And so that's what I did. I took the opportunity and ran with it and started this whole new service line specifically for this patient population.
And how long has this service line been up and running?
So initially, we started in 2022 more on the inpatient side and just really looking to see what are our true gaps and elevating nursing practice around comfort levels with feeding tubes and trying to drive safety related to enteral feeding tubes and making sure that we really have the clinical acumen to take care of this patient population. And then once we determine that there really is a significant need for patients outside of the hospital to have somewhere to go if they need their tubes to be managed, I started seeing patients in the outpatient setting in 2022. And it started very slow. I'd see maybe 1 or 2 patients every 2 weeks kind of thing. But then as word started to get out, it started to get busier. And originally we were very focused on tube management, just the management of the actual feeding tube itself. But enteral nutrition it's a pretty vast science. And so we knew that these patients would need so much more than just care of the actual device, care of the actual feeding tube. And so we've grown the service line and we have gastroenterology providers who specialize in nutrition care. So we have physician presence in our service line. And we added a dietitian who specializes in enteral nutrition as well. And really looking to make this a very rounded service that the patient can come to have a good nutritional assessment, make sure that they're on the right formulas, that they're maintaining their weight, that they're reaching the requirements that they should for their macro and their micronutrient intake. And at the same time, managing the tube and doing tube maintenance and tube exchange when the device needs to be changed. And one of my biggest passions is really individualizing the patient's feeding tube to the needs of the patient and for quality of life. And looking at the style feeding tube they have and saying, what is the quality of life with this tube? And is there some way that we could improve that quality of life if we change this tube to a different style feeding tube? And that brings me a lot of joy and a lot of fulfillment in what I do, is just helping the patients develop a good relationship with that feeding tube, because if they have a good relationship with the tube, it's going to work. If they're struggling with the tube, it becomes a barrier. And then if it's too much effort to get things hooked up because the tube is leaking, they're going to skip a meal and then they're going to lose weight. And then all kinds of other problems start to happen. So it's really looking at the patient as a whole and really optimizing their nutrition from every aspect. And I feel like with our gastroenterology nutrition specialists in the service line and with our dietitian, and then with myself as the enteral device access sort of expert, we can do that. So it's been a slow but sure journey, and it's not perfect, and we still have a long way to go, but I think we're moving in the right direction.
What's the makeup nowadays of the number of consults that you have in a given week or month, and what percentage of that is hospitalized patients versus patients on the outpatient setting?
So just, I guess, if we could average it out by week, on Mondays, Wednesdays, and Fridays, I'm on the inpatient setting side. And then on Tuesdays and Thursdays, I'm in the outpatient clinic. But right now, and that's just me, but with us adding those other providers to the clinic, there's usually somebody in clinic 5 days a week for the outpatient folks, which is really nice. But for me, who really specializes in the device, the access device itself, I'm there Tuesdays and Thursdays. And I think I saw about 400 patients last year, and I'm only open in the mornings right now. So just a Tuesday and a Thursday morning. So from going to seeing 1 or 2 patients every other week, it's probably, my clinic's pretty full every week now moving forward. So it's expanded quite remarkably.
And so those patients are coming in for a visit just to see you. It's not
Yep.
a combo visit. They're coming in for you for guidance around the feeding tube.
Yeah, so it's a little bit of both. So sometimes it's just a straightforward, the tube needs to be exchanged. It's been in for 6 months. It's starting to leak. The balloon keeps deflating. The tube needs to be changed. In that case, we take it on a case-by-case basis as if just tube management, and then it's most appropriate for the patient to just see me. Or is this tube management and would really benefit from a dietitian appointment and seeing myself and a dietitian? Or is this somebody who is struggling with underlying pathology and they've reached the point of malnutrition, and we're at the point where we need to make a decision? Is this somebody who needs to get started on an enteral nutrition feeding? That individual would benefit most from a combined visit. So the physician, the dietitian, and myself. So we offer all three. For the straightforward, just the tube management device management piece, that's the majority of the patients that I see in clinic.
And nowadays, where are most of your consults coming from? Where are they originated from? The PCP? Is it neurology for stroke patients? How are patients getting to you nowadays?
Yes. A lot of it is internal referrals from within providers that are working in the hospital setting that have learned about our service line. Within the Digestive Disease Institute, we get a fair amount of referrals from colleagues. And then I get a lot of patients sent to me from our head and neck surgeon. A lot of those patients require temporary feeding tubes in the immediate post-surgical recovery period for head and neck surgeries. And I get a fair amount of referrals from there. I get referrals that come through from the oncology side for patients that are struggling to maintain their nutrition during chemotherapy, radiation therapy treatments. And we're doing supplemental feeding, so I get a fair amount from there. Neuro, they're coming from all over. Skilled nursing facilities are sending patients in from the outside as well. PCPs, oftentimes patients will just call and say, hey, I have a feeding tube and I'm really struggling to get somebody to help me with it. And then we have a system where our schedulers will type in the word feeding tube, and then they type in a keyword, and then providers who take care of those patients will pop up. So my name will pop up, and if there's room on my schedule, they get those patients scheduled with me.
What type of outcomes are you seeing from this new service line?
A lot of it is the tube maintenance piece, right? And so getting these patients that had no idea their feeding tubes maybe needed to be changed every 4 to 6 months or once a year on a routine schedule for tube maintenance and tube management. When you do that, then the opportunity for complications is more reduced. Is this individual experiencing less complications? Are there less ED visits because the tube isn't falling out because the balloon is passively deflated after 8 months because the tube wasn't replaced on time? And then really looking at quality of life for these folks too. I have patients that come in and say, I absolutely hate this tube. I'd rather be without it. And that there is no alternative. Living without a tube is not an option. So how can we improve quality of life by changing this to a tube that works better for you, that is more cosmetically appealing to you, that you can continue to play with your grandchildren on the playground without worrying about a tube snagging on something? So really looking at quality of life for these patients too. And then just, I think, growth of the service line too. How many patients are we seeing that never had access to a clinic where they could come and have tube maintenance done before. So those are the other things that we're looking at.
And so I'm inferring here that you're obviously able to bill for the services that you're seeing, even when you're independently seeing a patient without a provider there. What type of return on investment is being seen from the existence of this program?
When you are working in a role where you can bill, and as clinical nurse specialists working at the top of license, you have your NPI, which is our National Provider Identification Number, which every single CNS out there should have. And then we have the opportunity to bill. The rule of thumb is they like you to bill your salary at least, so that you're paying your own way kind of thing. And anything over and above that obviously is very nice. And if I weren't doing that, I think I would have been informed of that, put it that way. That's my measure. When things are going well, nobody complains, but if things were not going well, I'm sure I'd hear about that. But I do know that's the general rule of thumb. If you can prove your worth by billing at least your own salary, then that's usually a good goal sort of thing. I don't crunch the numbers and do the finances. For me, my greatest satisfaction comes out of offering the service to the patients and taking care of them. But I do know, obviously, there has to be fiscal responsibility involved with that. And that's the other nice thing about a clinical nurse specialist. There's many who don't bill, but just helping them understand that the opportunities to bill are there, and that it's strongly encouraged for all of us, because it really validates our place in the profession as advanced practice nurses.
When you started this service line, to your knowledge then and to your knowledge now, are there any other healthcare systems that are operating a service line like this to meet this specific patient population's needs?
There aren't some. I know that there is a service line at Strong Memorial in Rochester, New York, and I networked very closely with the nurse practitioner who works in that clinic, and she helped provide some guidance when I wanted to get this clinic up and running and started, because I didn't really have a baseline. The service line didn't exist. It's like, where do you start? Where do you go to? So I did some looking around and actually did a little innovation trip out there and just got the lay of the land and I had a vision of what it should look like, but to see it in practice was really nice. And the other one that I'm aware of is at Mayo Clinic, and they have a very strong enteral nutrition footprint and are really providing a great service for this patient population as well. And those are the ones that I know of. There may be others that I'm not aware of, but I do know of those.
And so are there other examples within the Cleveland Clinic enterprise system where this type of model is being used, where you have a CNS that is attaching themselves or growing a model of care specific to patients that have unique needs? In this case, feeding tubes, but maybe the case is for some other type of unique need that they have.
Yeah, absolutely. And the one that comes to mind right off the bat is our wound care consult team. We have a really strong clinical nurse specialist presence that are driving care and providing direct care, as well as driving nursing outcomes and patient outcomes for patients with wounds and patients at risk for developing pressure injuries. And they really do. Clinical nurse specialists really are at the helm of that and leading the charge for that patient population as well, certainly at my organization for sure.
Your service line was really a bottom-up approach where where you came up with the idea and proved the need, and then you had support from your leadership. What would you tell a nurse executive that's thinking about their own health system, and where are great places for me to ask CNSs to be involved in the development of meeting unique patient population needs? How do I involve CNSs and leverage them if I don't have a model that exists like this?
First of all, it's really important that nurse leaders truly understand what a clinical nurse specialist is and the scope of our practice as a clinical nurse specialist. Become familiar with the National Association of Clinical Nurse Specialists definition of a CNS, and then look to see where are the gaps in my organization and how could we fill those gaps, and how could we use a CNS to really bridge those clinical gaps that we see in the organization. And when CNSs truly live out and practice by the definition of the CNS, then gosh, there's so many opportunities. I feel I do the enteral nutrition patient population, and if nobody's paying attention to that patient population in their organization, that's a great place to start, because I feel like it's a bit of a forgotten patient population. Like, people think it's nutrition. It's not that big of a deal. If we hang the wrong formula, is it a medication error? Yes, it is. If we clog the feeding tube, is that a problem? Yes, it is. It's a safety issue for the patient. They're not getting their medications. My passion, clearly, but I feel strongly that the enteral nutrition patient population should have representation by some kind of a team at every single organization. I think I gave the example of the patients with wounds and wound care. We have patients that are susceptible to infections and sepsis and central line infections and urinary tract infection because of catheters that they need. And clinical nurse specialists are just so well positioned to drive metrics and to drive quality and to drive care for those patient populations. Patients that are at risk for falling in the hospital, that's just, it can be so catastrophic to a patient. And so looking to your CNS team, looking at your rate of falls and saying, how can we use our CNSs and leverage their clinical acumen and their knowledge, their training, their licensure, and really push them to the top of that to reduce falls and injuries related to falls in the organization. There's so many opportunities where we can sink our teeth in and really drive metrics and make a difference.
So you came up with this idea. You thought that there may be an opportunity here for your own service line. I understand the journey of how you got there, but and more of your interaction with nursing leadership and what that process was like from a proof of concept to creating, in essence, your own, you basically created your own job, if you will, is what I'm hearing from you. Please correct me if I'm wrong. What was that experience like? How did you get that support and that buy-in from your nurse executives?
I think the timing was just very fortunate, in addition to me having an interest in enteral nutrition. And like I said to you, I developed this interest when I was working with the neuro patient population, because we were placing a lot of feeding tubes in those patients. And when I was working with that patient population, we would have patients that would come in with a stroke, get their acute stroke care, make a significant recovery, and now they're at the point where they're ready to go to acute rehab and continue their recovery and continue their journey to really independence again after stroke. And so sometimes, like I mentioned, those folks would have a feeding tube and they'd be all teed up for discharge and ready to go. And the feeding tube inadvertently pulled out while the patient was up with physical therapy, getting up to a chair. And so now the discharge is on hold because we have to get a new feeding tube in place for this patient. And ambulance transportation's coming at 2 and they can't come at 3. So now they'll have to wait until tomorrow. And wow, that's a discharge delay for this patient. And if that's a Friday afternoon, sometimes it was the whole weekend that would be delayed. And that's where I started to notice the gap for this patient population. And we had a small team that were placing feeding tubes within the organization, but we're a large organization. We have a lot of beds, especially at the main campus, close to 2,000. If there's 15 patients waiting for a feeding tube, we might not get them all placed in a day just by nature of the procedure, and it takes some time and such. And so that's where my interest peaked at the beginning. And then in 2020, when COVID was really starting to become at its peak, we had a lot of patients in our critical care areas that needed feeding tubes. A lot of them required feeding tube placement prior to being proned onto their bellies so that we could really ventilate them and recruit all that lung space. And so the team that were placing tubes, which was a small team at the time, were really struggling to meet the metrics of just the demand during that COVID time. And so they would call me and ask if there was any way I could help get the feeding tubes placed for patients outside of the neuro department. And so I said, absolutely. Of course, I was willing to help anywhere. And so that sort of got my foot in the door more in the Digestive Disease Institute. And the director at the time, who has since retired, she always knew that there was this huge need for this patient population. And I think it was desired, but there wasn't really, I guess, the wherewithal for somebody to just take charge of it and run with it, because providers working in the field had a lot of other competing demands. And there's a whole intravenous nutrition therapy program at the clinic that is very demanding and it's very skill intensive, and a lot of attention was fed into that program, and there just wasn't somebody to drive the enteral nutrition side of things. But there was always that desire. I think it was just a matter of when the director of the Digestive Disease Institute at the time came into contact with me, who had an interest in enteral nutrition, it was just like, wow, I would love this opportunity. And they'd been waiting for somebody to take charge of this opportunity. And I think COVID definitely helped in a way. If there's any positives related to COVID, is that just got me that exposure within the Digestive Disease Institute. And then it was a conversation. We'd love to start an enteral program. Would you be interested? I'd love to get the enteral program up and running. You never say no to an opportunity like that. You always say yes, and then you figure out how to get it done. And then the conversation kind of went, well, we don't really have a job description. We'll have to craft one. And I was like, okay, happy to help. Looking at the roles and expectations of a clinical nurse specialist. And then they'd never worked with clinical nurse specialists and not hired a clinical nurse specialist into this kind of a role in the department. So really just for me, having an opportunity to socialize the role and say, hey, this is what I'm capable of. This is what I can do. This is what I love to do. These are the opportunities I see. These are the gaps. This is my vision. This is my dream. Hey, why don't we have an outpatient clinic for these patients? And then the other side of the conversation was like, oh, we've always wanted to get that up and running. We haven't been able to, and there hasn't been the resources and there hasn't been the drive and the interest in it. And so I think it was just like a marriage of all the perfect things that came together at the right time, with having those crucial conversations and being bold enough to have those conversations and say, this is what I'd love to do. This is what I have to offer. Should the opportunity arise, speak to me about it, kind of thing. And I wasn't looking to go into anything new at the time. I was very comfortable in my role in the neuro department, and I loved what I did. I just felt this really strong pull towards this patient population with this unique special needs that I felt there was such a big gap. And is there an opportunity for me to make a difference for these patients? And the more I thought about it, the more I realized there was. And so when the opportunity presented itself, I ran with it. And I think it was just everybody coming together at the right time in the right place. And again, just having the courage sometimes to drive those conversations and put yourself out there and to really just highlight the uniqueness of the clinical nurse specialist role, because I knew it wasn't just going to be about taking care of patients. I knew that there were so many opportunities related to elevating nursing practice, related to feeding tubes, and driving system-wide organizational change related to the style of feeding tubes that we're using and the connection style of feeding tubes that we're using, from a legacy friction fit to an end fit, twist and lock fit, which is a much safer feature for a patient. But I knew that would be a huge undertaking, a massive project, and I wanted to be part of that. And I feel like a clinical nurse specialist should be on every team that's undertaking these huge organizational and system changes. It was just, I feel, an opportunity to do what I trained and was educated to do and have the license to do and the passion to do.
Any closing thoughts as we wrap up this episode?
Promote the CNS role within your organizations and to really just provide an arena that promotes CNS practice at the top of licensure and certification, training and education we're advanced practice registered nurses. It's vital to recognize us as advanced practice registered nurses and tap into our potential to transform care, especially for specialty patient populations. I think we're sometimes an untapped revenue stream, so provide the opportunity to consider billing for clinical nurse specialists within the organization, as well as healthcare outcomes for patients. I think it's like the dream for every CNS.
Addressing the needs of unique patient populations has been our episode topic. My guest with her dream job, Lauren Bruwer. Thank you so much. Appreciate your time today.
All right, thank you.
You've been listening to the BRG Nurse Executive Podcast, which focuses on improving patient care by advancing nursing leadership. The views and opinions expressed in this podcast are those of the host and podcast guest and do not necessarily reflect the opinions, position, or policy of the guest employer, Berkeley Research Group, or their other respective employees and affiliates.